Good morning, everyone. It's good to see such a big crowd. Can you guys hear me okay? Trying not to talk too loud because I know he's going to amplify me. All right. So before we get started, I just want to let everyone know if you need the restroom during my presentation, it's right down the hall past the front desk. You're welcome to leave whenever you need to. So just to introduce myself, my name is Emily Bishop. I'm a speech language pathologist with the hospital with Novant Health, but I primarily work in outpatient. So I'm over at Novant Rehab Center on Oleander. It used to be called Oleander Rehab for any of those who are familiar with that. So at any time during my presentation, you guys can stop and ask questions, or if you have any comments you want to make, I'm totally okay with that. And today I was told to kind of just give you guys a little insight into what speech language pathology is and how it relates to Parkinson. So that's my goal for today. Any questions about me before I get started? It works? Speech therapy? Good, that's awesome. Where have you been, if you don't mind me sharing? Okay, very good. Awesome. Come on in. Yeah. What'd you say? Okay, good. That's great. Great. All right, so we will get started. Okay, so I'm going to start by just filling you in on what a speech language pathologist is. We're also called speech therapists. Speech language pathologist is our fancy name. So as a speech language pathologist, we work to prevent, assess, diagnose, and treat speech, language, social communication, cognitive communication, and swallowing disorders in children and adults. So today my goal is to focus on the areas that we primarily see related to Parkinson's. There are other areas, as you see, that we work on, but I'm going to dive deeper into the ones that we see mostly with Parkinson's. So my first, I also wanted to go into where speech language pathologists work, so you guys know the different options you guys have for therapy if you ever want to pursue speech therapy. The first place is obviously hospitals. I work for a hospital, so you can receive speech therapy while you're in the hospital, like in acute care if you need it. There's a rehab hospital with Novant as well, the inpatient rehab hospital where I work as well, some just part-time. And then of course in outpatient. So there's outpatient clinics or private practices, just like doctor's offices, skilled nursing facilities or nursing homes, VA clinics, home health, which is where therapists or skilled nursing comes into your home to provide therapy or treatment, colleges and universities. So there's speech language pathologists at universities who help people like me that was in grad school teach us how to be a speech therapist, or in a research setting doing research. And then also we work in schools and daycares. All right, so my first area I want to go into today is related to swallowing. So our fancy word for any disorders of swallowing or difficulties with swallowing is dysphagia or dysphagia, some people say. There's 3 stages to swallowing. There's the oral phase, the pharyngeal phase, and the esophageal phase. So the oral phase, to go into more detail about that, is related to the mouth. So we're looking for patients' ability to have good lip closure. So being able to close their lips when they're chewing and moving food around so that nothing's spilling out. We're also looking at tongue control and movement. And then we're looking at mastication. Mastication is our fancy word for chewing, how well people are able to chew their food and control it in the mouth. And then we're looking for, after the swallow, after someone swallows, if there's a lot of residue left in their mouth, if there's a lot of food still hanging out in their mouth. So that's kind of the oral phase and what speech language pathologists look for with the oral phase. And then the pharyngeal phase is your pharynx, is also known as your throat. So that's the part where we're going in and looking at your throat and what's happening there. So with that phase, we're looking at the initiation of the swallow and how quickly your body is protecting your airway during that swallow. So I'll go into the anatomy a little bit more in a second so you can kind of see how that works. And I also have a video of a typical swallow. But the most important thing, no worries. The most important thing is that our airway is protected when we're swallowing. Otherwise, we're going to have that sensation of coughing or choking when we swallow. So we're also looking at soft palate elevation. And I'm going to kind of try to point to this over here. I know it's hard to see. Do I have to get closer? Trying to point at it's going crazy. I know. I'm just trying to point at that diagram. Okay, that's all right. No, the diagram where it says the soft palate, kind of, it's up at the top. It's the pink structure kind of behind the yellow. Yep. So it's hard to see on there, but the soft palate, that closes off when you swallow, it raises up, and that closes off your nasal cavity. So if you've ever had liquid or food kind of spill out your nose or come back up, that soft palate's probably not working like it should. So that's one thing we look at with the swallow. And then we're also looking at laryngeal elevation. So your larynx is also known as your voice box or your Adam's apple area. When you swallow, that moves up and forward to open up the back of your throat for everything to spill into the correct tube, so to speak, when you're swallowing. But it also closes off your airway too, so that's important. There's a lot of things we're looking at that are very technical with the pharyngeal phase of swallowing, but these are just some things. And then we also look at the muscles in the throat and their strength to be able to contract and push down food as you're swallowing. So our goal with swallowing is to look at if there's any weaknesses with the oral or pharyngeal phase. And then we're also checking to see if aspiration occurs. So if you've ever heard of the word aspiration, that means food or liquid entering your airway, which we obviously do not want that to happen, because if that happens consistently, it can lead to pneumonia. So that's usually one of the biggest concerns that physicians or doctors have is especially with Parkinson's is, okay, are we coughing a lot when we're eating or drinking? Why is that happening? They usually send you to a speech therapist to assess that because we don't want you to have pneumonia. And then the esophageal phase. So we look at the very top of the esophagus with swallowing, but we cannot treat or diagnose anything with it. That would be a gastrointestinal doctor. So a GI physician would be the ones we would typically refer you to if we feel like the issues are coming related to the esophageal phase. Okay, so next I have a little video if we can get it to work. And this just looks at what a normal swallow looks like.
This side view of the head highlights structures involved with swallowing. That includes the tongue, teeth, epiglottis, and esophagus. The teeth grind and chop food into tiny pieces, while the glands in the mouth moisten it with saliva. Then the tongue pushes the moistened food, or bolus, to the back of the throat and down into the esophagus, which leads to the stomach. Let's watch the swallowing process again. First, the tongue pushes the food into the throat. Next, the epiglottis, a small but important flap of tissue, folds over the voice box at the top of the windpipe. This keeps food from going down the wrong way. Finally, the esophagus contracts and moves food towards the stomach. Excuse me.
Whoever created this video had quite an imagination. Okay. So our next slide we're going to go into talks about assessment. So what we as speech language pathologists do to assess for these things so that we can then provide treatment for you guys. So our first thing we have is a clinical swallow evaluation. The purpose of that is to determine the presence or absence of signs and symptoms of dysphagia, with consideration for factors like fatigue during meals, posturing or positioning, and environmental conditions. This exam gives us an idea of whether we need to pursue an instrumental assessment. So typically a clinical swallow evaluation for me looks like I go through your case history, what's been going on, any of your medical diagnoses, and then we talk about your signs and symptoms you may be having. And then I will have you eat and drink different consistencies. So I usually give you what we call a thin liquid, which is just water, juice, something like that. That's real thin and watery. And then I have you eat a puree or pudding consistency, so applesauce or pudding. And then I would have you eat a soft consistency. So it's usually like a muffin, a little Debbie cake, a Nutri-Grain bar, something that's kind of soft. And then I skip to a regular solid. So typically in our clinic, like I said, I work in outpatient. For the regular solid, what we typically have is like a cracker. So it's going to be a graham cracker, something that's dry, crunchy, flaky. Sometimes that's harder for the body to handle. So that's what a clinical swallow evaluation looks like. I would have you eat and drink those things. And I'm just going to watch you. I'm going to feel your throat to feel for laryngeal elevation, that Adam's apple or voice box moving up and forward. I'm going to look at how you chew, what's left in your mouth after you swallow, and determine if we need to get an instrumental assessment. Most of the time, and really lately, our field has really been pushing for those instrumental assessments right off the bat. So, and that's what I would recommend too. But if you're unsure whether you need to pursue one of those, typically your doctor will send you to us first to just have this clinical swallow evaluation. And then we'll say, yeah, we probably need to do an instrumental assessment to see what's physically going on with inside. So those are what I'm going to go into next. We've got two instrumental assessments. One is called a modified barium swallow study or a video study. And then we've got a FEES, which stands for fiber optic or flexible endoscopic evaluation of swallowing. Both tests are great. There's not one that's better than another. It just kind of depends on the patient, what they're comfortable with, and what we need to assess. So I'm going to start by talking about the modified barium swallow study. Have any of you guys had any of these procedures done? Yeah, good. Okay. Awesome. So a modified barium swallow study is a radiographic procedure that provides a direct dynamic view of the oral, pharyngeal, and upper esophageal functions. So this is an X-ray test. Here with the hospital, we have, obviously in the hospital, they can do these tests, but also in outpatient, they do them over at the medical mall or medical plaza, I think it's called now. But it's just an X-ray test, and it's done with a speech language pathologist and usually a radiologist or radiology PA. Those are the two people in the room looking at your swallowing. So this test is beneficial for identifying whether aspiration has occurred. Again, there's my word. Aspiration means things going into your airway. And then it also looks at any weaknesses within the throat or where breakdowns are occurring, so that as speech pathologists, we know what we need to work on. Let's see. That's kind of the biggest takeaway. It looks like the clinical swallow evaluation. They would have you eat and drink similar things to what I mentioned earlier, but you're going to have a little bit of barium on it. It's not a ton of barium, just a little bit. And that's what allows them to actually see it going down. Any questions about that procedure right now? No. Okay. Typically, reasons we would not do that test would be if a patient has a hard time maintaining an upright position. We do have to put you in a little X-ray machine. So that's really the only thing that would keep someone from having that. Or if they have an allergy to barium, that would be the only other thing. And on the next slide, I have pictures of both of these tests. So you'll be able to see kind of what it looks like. And then the next one I want to talk about is the fees, or the fiber optic endoscopic evaluation of swallowing. So with this procedure, it's a small flexible tube that's inserted through the nose, allowing visualization of the inside of the throat. So it's a little scope. If you guys have ever been scoped by an ENT, an ear, nose, and throat doctor, it's a little bit different than that because we're putting that scope in there with just a little bit of lubricant on the end to help it slide through your nose. And then we're holding that scope there while you eat and drink so we can see what's happening. Now, most people are like, ooh, I don't know about that. I don't really want something in my nose. But I will be honest with you. When we were training to be able to do this test, I had it done like 15 times in a row to myself by people learning how to do it. And it really wasn't that bad. It's a little uncomfortable, something in your nose is uncomfortable, but we try to stay in the lowest nasal cavity to get to your throat. So we're not going super high up. And so it's really not as bad as it may sound, but so anyways, with this test, what we're doing is putting that tube in your nose and sitting at the top of your throat. So the camera is looking down into your throat. We're going above it, looking down in there. And this will display on a computer screen. So if you're comfortable and you're not a queasy person, you can watch your swallowing on that screen while we're doing the test, which actually gives us really good feedback on what's happening. Yes, sir.
Isn't it always sprayed through the nose and out? In other words, so you really don't feel this,
So that's a good point. Actually, with speech therapists, we do not do the spray because we don't want anything to be numb. So it's not in case it doesn't work like it normally would. Because if we numb some of those structures, things might not close off like they normally do. Now with an ENT, they typically do the numbing spray because they're not looking at the swallow function. They're looking at your vocal cords or just the anatomy at rest. But yes, that's a good point. So we don't use the numbing spray typically, or really ever. It's just a little bit of lubricant on the end. But we do offer this test in our clinic over an outpatient, which is kind of a perk of it. You don't have to go to the medical mall or the hospital to have it done. The orders from your doctor come straight to us to do the test in our clinic. And so that's nice that we don't have to go there. And so same thing with this test, we're going to watch you eat and drink different consistencies, foods and liquids. This time it's with no barium. We just put a little bit of food coloring in the food and drink to kind of see it down and differentiate between the food and liquid and your just saliva. So we know what's what. The only contraindications for this test would be, obviously, if the patient's not comfortable doing that test, we wouldn't do that one. Or if you have someone who has consistent nose bleeding, if you have nosebleeds a lot, we would probably skip this test because we don't want to make you have a nosebleed. But out of the research shows that there's only a few, like a small percentage of nosebleeds that actually occur with this test. And when they do occur, it's usually patients who have them frequently. So it's usually not something we have to worry about. Even when I had it done to myself 15 times in a row, my nose didn't even get a slight bit of blood. So, all right, any other questions about that procedure? No? Okay, and I can always come back to things later if you guys have any other questions. All right. So here you can see on the left side of the screen, that is the modified barium swallow study. So that's the X-ray test. As you can see, there's kind of like, we call it a C-arm that swings in front of on the side of you to get that sideways view. And then there's a TV monitor on the side that the speech language pathologist and radiologist is looking at while you're swallowing. Now with the modified barium swallow study, everything is a really quick picture because we're trying to reduce the amount of exposure you're getting to radiation. So that's another, thing with the fees versus the modified barium swallow study is the fees, we can do that test for as long as we need to. Whereas the modified barium swallow, it's going to be a really quick procedure because we don't want to expose you to a lot of radiation. So that's kind of what that looks like. And then on the right is the fees. That's the camera that goes through the nose. That was actually a picture I took of 2 speech language pathologists that I work with in outpatient. That was when we were doing our training course, and they gave me permission to put their picture up there. So you can see what that little scope looks like. It's a very, very, very thin tube, and she's looking at the computer screen that's across from her. All right. So dysphagia treatment. So dysphagia treatment, this is the good stuff where we tell you what we can do to help. So if on one of those instrumental tests, we identify there's weaknesses somewhere between the mouth and the throat, this is what we have to offer. So the first and foremost thing that we typically do are swallowing exercises. There's a couple different ones, and those exercises we provide based on where the weakness is in the throat or mouth. So it's not like, oh, just do this exercise, it'll help. We prescribe them based on where the weakness is. So that's why that instrumental assessment is really important. And then postural or position techniques. So sounds like what it is. We obviously want to try to have an upright position when we're eating. And if we're not able to do that because of weakness or whatever, we'll try to figure out ways that will help kind of compensate for it. So, and then sometimes there can be different strategies you can do with your neck or head to help ease your swallowing. So sometimes a chin tuck may help. That's not always, though. Some patients might have said, oh, my friend or my doctor said, just tuck your chin when you swallow. That might help. That's not always the case. These are things we have to trial on our instrumental assessment to see if they actually help or work. And then obviously pacing and feeding techniques. So sometimes there can be adaptations we can make to the way you eat to help ease transit. Electrical stimulation. So there are electrodes that we have that sometimes we can put on the throat or the face to kind of give muscles the boost that they need during these swallowing exercises that we prescribe. Now, there are some contraindications to electrical stimulation. So before just signing up for that, you would definitely want to talk to a speech therapist about those contraindications, because sometimes I know I've had patients with deep brain stimulators for Parkinson's, and we would not do stim on that because we don't want to throw anything off whack with the deep brain stimulator. And then the next thing we would try would be diet modifications. So if on the swallow test we saw someone had aspiration, whether it was with liquids, whether it was with solids, we would probably recommend modifying your diet, initially at least. So that may mean sticking to softer foods or kind of chopping up your meats instead of just taking a big old bite of chicken or steak. Then we would try, sometimes with the liquids, I feel like that's mostly what we see, a hard time swallowing liquids. We would suggest putting some thickener in the liquids because it helps to slow the transit. And there's different brands and different types that we would recommend based on your swallow test. But that's sometimes what we would try in order to reduce the risk of aspiration and pneumonia occurring. So And then medical intervention. We typically obviously cannot provide medical intervention, but other physicians may do that, whether it's some sort of surgery, injections, or just medications like for reflux, like I was mentioning earlier. Yes, sir.
How long is the barium gestation? How long is the feed?
Yep, that's a great question. It depends on the patient, but typically the barium swallow is the actual test itself is maybe like 5 to 10 minutes. And then the speech therapist usually spends time kind of educating you on what she saw, he or she saw. And then the fees, that camera, the scope test is, we can go for as long as we need to, but I would say on average, it's about 10 to 15 minutes. So they're both short.
Well, with the barium test, you do try different food samples?
Yes.
Not just one?
Yes. Yep. Same thing. We, on all of them, we try different consistencies to see what may be giving problems or not giving problems. Any other questions about treatment? I know this is, but yes, sir.
So, how do you help cognitive?
Okay. I will touch on that at the end. How about that? Okay. Yes, so with dysphagia treatment, I know this is just very like overview general. I don't want to go into too many details, but just kind of giving you an idea of what speech therapists can do and how we can, if you want to go see one, what we have to offer. All right, so the next area I went into is speech. So our fancy word, our medical term for speech disorders is dysarthria. So dysarthria is defined as a group of neurogenic speech disorders characterized by abnormalities in the strength, speed, range, steadiness, tone, or accuracy of movement required for breathing, phonatory, resonatory, articulatory, or prosodic aspects of speech production. So that's a mouthful. So let me break it down a little bit. So when you think of a speech therapist, you think of just helping people talk, right? But it's a lot more goes into that with the speech aspect. So we're looking at, when it says breathing, we're looking at breath support. Are they able to breathe from their lower abdominal area, diaphragm, or are the breaths very short and coming from up here in the chest? Then we're working our way up from our lungs up to the mouth. So we're looking at phonation. Phonation means voice, the ability to create voice and how that voice sounds. And then we're looking at the resonance, which is how the voice sounds. So sometimes patients may have nasal air emission, meaning like their voice kind of comes out of their nose or something like that. That would be resonance. And we would look at why that's happening and how we can help with that. And then obviously articulation. So that's our word for how the lips, teeth, tongue, jaw are moving to form the sounds and if that's accurate. And then we're looking at prosodic aspects. So prosody is inflection and intonation, the ability to kind of create pitch changes in your voice, or if it's just one flat prosody. Okay. So I went specifically into hypokinetic dysarthria because that is the type of dysarthria that is typically seen with Parkinson's. Now, it's not always the case, but that's kind of the one that research has shown sticks out in those with Parkinson's disease. So the speech characteristics for hypokinetic dysarthria include monopitch. Pitch is being able to change the tone, the inflection of your voice going from high to low. So typically it's just kind of one flat pitch, one loudness. So it's difficult to increase loudness or reduce loudness. That's the next point, reduce loudness or stress. Tendency for rapid or accelerated rate of speech. So that just means your speech is really, really fast and sometimes it can be hard to understand. So we've got pacing techniques to try to help you slow that down. And then rapidly repeated phonemes. Sometimes that kind of just means like stuttering or disfluency of speech. So sometimes that can happen at initiation of speech with Parkinson's or other neurological conditions too. And then I'm going to skip the blurred AMRs because that kind of goes hand in hand. And then the physical characteristics are on the other side. Those are just related to Parkinson's and typically what goes hand in hand with speech and the physical characteristics. A lot of my information today comes from ASHA, which is the American Speech Hearing Association, which is our governing body for speech therapists. They provide us with a wealth of resources. So a lot of what you're seeing today, you can go and find on their website as well. Again, that's ASHA. That's where I pretty much took this information for this slide from. All right, so for treatment options with dysarthria or speech disorders, we've got restorative and compensatory approaches. So the restorative approaches, we're training the different speech subsystems, focusing on respiration, intelligibility, and prosody, like I was saying, the different areas and ways to help strengthen those areas. A lot of times it's through really focusing on breath support, because that's one of the biggest things I've noticed that is hard to retrain. We get so used to taking short, little small breaths from up here, but our power is really going to be coming from our diaphragm and from our belly when we breathe. And then compensatory strategies are training to improve the comprehensibility of speech by focusing on use of communication strategies, modifying the communication environment, and using multimodal communication. So modifying the communication environment would take education for both the patient and the caregiver on how we can modify things within the environment. So sometimes, we're trying to communicate over the loud TV that's in the background or yelling across the house. Okay, can we find ways to not do that or overcome that? And then multimodal communication, that looks like using things other than just your voice and speech. That's going to be using gestures, facial expressions, and we also have other devices, AAC devices, which stands for augmentative alternative communication, where we can use like picture exchange, where we're using pictures for communication. Now, typically when we would use that would be in a pretty severe situation where the patient has lost the ability to communicate verbally. And so there's different devices and companies that we work with that would help provide devices to kind of augment communication if it came to that. All right, any questions about speech right now? Okay, let's move on. All right, then we're going to go into voice. So speech and voice kind of go hand in hand with Parkinson's, but specifically voice disorders, our medical word is dysphonia. And dysphonia is defined as it occurs when the voice quality, pitch, and loudness differ or are inappropriate for an individual's age, gender, cultural background, or geographic location. So if you've ever had, even right now, I can feel my voice is changing from talking so much. So I'm going to actually take a sip of water. So you guys may have noticed some changes in your voice since you've been diagnosed with Parkinson's, whether it's weaker, not as loud, not as strong, or maybe hoarse too. Those are things that speech therapists look at and can help with. And then I took the second definition, which is hypophonia. So phonia stands for phonation. Dys just means kind of like dysfunction. And then hypo means lacking or reduced. So hypophonia stands for reduced vocal loudness. And that's one of the key characteristics that we can see in Parkinson's. So I'm going to go into, on the next slide, more specific treatment about there's a treatment designed specifically for patients with Parkinson's with that. I lied. I'm going to talk about assessment first. So assessment with voice, we always want you to see an ENT or an otolaryngologist, an ear, nose, and throat doctor, because we want them to visualize the anatomy. They're the experts on voice. So they would be the ones to look at your anatomy, make sure there's nothing physiologically wrong before we would start any sort of voice therapy. So they do the assessment, then they refer you to us for treatment and assessment for speech therapy. So as a speech therapist, our assessment looks at case history. We're going to ask you questions about your history, what's been going on, how long that's been going on, that kind of thing. And then we would typically have you rate yourself, rate your own voice. There's different forms and patient rating scales that we have to give you that look at different qualities of the voice, and it just gives us good information on how you rate your voice now, so that when we're done with treatment, you can kind of rate it again and see if you feel like there's been improvement. And then we're going to assess respiration again, which is breathing, because that's really, really important. And then we're going to look at clinical acoustic measures of vocal quality. So vocal quality, we're going to look at roughness of the voice, breathiness, strain, pitch, loudness, etc. Just the different qualities of voice. Yes, sir.
Do you ever ask the caregiver or people around you for their assessment of your voice?
Absolutely. So, and I should have included this at the beginning. When we take you guys back for assessment in our office, it's different in the hospital setting, but in outpatient, we love for a caregiver or family member to come in and give their input, as long as the patient's comfortable with it. But that gives us a good idea, because there may be things that the patients with Parkinson's may not identify or know is occurring that you've maybe picked up on. So yes, absolutely. All right. Okay, so now we're going to talk about voice treatment. So the biggest one, you guys may have heard of it, is LSVT Loud. So that stands for Lee Silverman Voice Treatment. And the one related to speech therapists is LSVT Loud specifically. You may have heard of LSVT Big. That's typically related to physical therapy and occupational therapy. But this is the one designed for speech therapy. So LSVT, it was named after Miss Lee Silverman. She was a sweet lady who had Parkinson's disease, and her family kept saying, I really wish I could just hear her and understand her. I have the hardest time hearing her. And her doctor actually went on to develop this whole treatment program based on her. So the research began in around 1987 by Dr. Lorraine Ramig, who has a PhD. And she designed this program, and it helps to train people with Parkinson's to use their voice at a more normal loudness level while speaking at home, work, or in the community. So sometimes with Parkinson's, there can be a mismatch between how you think you're talking and how you actually sound. And why this happens, not 100% sure, but the body kind of calibrates to this normal setting of, okay, this loudness sounds normal, but it may not be quite loud enough for average conversation. Yes, sir.
Yeah, I went through speech therapy and I was fine while I was doing it.
Yeah.
But then afterwards, I went back to speaking softer again.
Mm-hmm.
Is there any kind of instrument that could show you how you should, be at a certain tone?
That's a good question. There are voice sound meters, and that's what we use in our treatment with LSVT. So usually LSVT is done, or it needs to be done by a certified provider. So I am certified in LSVT. That's partially why they asked me to come speak today, because we went through this extensive training and online education and practice to learn how to do it and implement it for you guys. So part of the treatment is using a sound meter to level measure the level of loudness during treatment. So there's apps, there's free apps online on your phone. I have one on my phone. You could just look up sound meter, voice sound meter. Now it's not going to probably be as accurate as like an actual device, but it's close enough to wherever you're able to measure. So did you have LSVT or was it a different kind of different? Okay. Yeah. Okay. Yes, sir. Okay.
You know if it's allowed. You remember it.
Yes. Yes. Yep.
So it goes over a month.
Yes. So that was the next point I was going to get into. It's a very intensive treatment. It's 4 times a week for 4 weeks, so 16 sessions. And the reason that is because it takes a long time to recalibrate to going from maybe this soft kind of monotone voice to being loud and projecting at a nice clear quality. And so the whole goal of it is about recalibrating the voice and speech. So the idea of this treatment is built on 3 key strategies. So the first being vocal loudness. That's our target for the treatment program. We're focusing on being loud, thinking loud the entire time, because the other things, the other speech characteristics and voice characteristics will fall into place if we can focus on the loudness. And the whole goal of the treatment is so the speech therapist would model what we want you to do, and then you would repeat it back to us. And then as you get more independent, we kind of fade our modeling and have you just do those exercises in your nice loud voice, and we give you cues and hints here and there when you need it. So the goal is vocal loudness. And then the mode or the intensity is the intensive dosage with high effort. We're putting a lot of effort in, just like if you've ever gone to physical therapy, they're working you hard, they're making you really strengthen those muscles. We're going to do the exact same thing with your breast support and the muscles within your throat for this treatment. And then our goal at the end and throughout is for generalization or calibration. And that just means we're recalibrating the sensory feedback. So people recognize their new, louder voices are within normal limits. And this increases the likelihood that people with Parkinson's will feel comfortable with and use their louder voice at home, work, and play. So a lot of times when we're getting started with treatment, and you may be able to speak into this more than I have, I've noticed patients say, I just sound so loud when I'm doing this. Like it's so loud. But it's actually not to the average listener. We're listening for that loudness so that you can be understood by your friends and family. So I know this is a very just generic overview. I do have a video on the next slide that goes into kind of a testimonial from someone who had done LSVT. And then I have a few handouts that I printed at home last night that's kind of goes over LSVT again. I'll give them to you guys after this. If anyone's interested in them, or you can look their website up too. So any questions on that before we watch the brief video? Okay.
I guess a comment.
Yeah.
I know someone who also has Parkinson, but who is deeper into it, and when I first met him, you can't get past that.
Yeah.
And as I was going through this, I thought about him a lot and started to talk about it. And he told me, well, my wife understands everything I'm saying. I said, that's it. In other words, you are not motivated to think any other way because she will always understand you.
Sure.
Or so far.
Yeah.
But I have managed just by developing our friendship further and prodding him that he will speak out. And my brother had Parkinson's also, same thing. Yeah. And my brother had this therapy, but this guy did. So anyway, the point is, family has to kind of respond and say, louder, please, this kind of thing.
Yeah.
Otherwise, they just get really comfortable.
Right, because they may not be aware that their voice is too soft. Exactly.
Frozen face, whatever the term is for it. My mother had it, her Parkinson, and I've had other people that I knew. And that's the muscular thing. Push through it.
Right. Yeah, that's great. Great information. Yes, ma'am.
Maintenance is a big issue. Jim had the LSVT maybe 4 years ago. Nobody here was doing it, so is it new that you guys are doing it?
Maybe so.
We had to travel all the way down to Supply
Yeah.
to get it.
Yeah.
But it didn't it didn't last.
Okay.
And I'm wondering, would Medicare pay for it again?
Yeah.
They would.
Mhm. I think so. Yep. I mean, I can't make any promises, but usually Medicare, as long as we can justify medical necessity, and to me, being able to communicate with your friends and family is a medical necessity. So, as long as we can justify that, yes, yes. Me. Yes. So I'm at it's Novant Rehab Center. It used to be called Oleander Rehab, right by Jungle Rapids. If you're familiar with where that is, we have physical therapy, occupational therapy, and speech therapy there. I am trained in LSVT as well as one other speech therapist there. So we offer it there. To my knowledge, I'm not aware of any other like private practices that have trained clinicians. There may be, but I just am not aware of it. So yes.
Yeah, does it require a referral,
Just a speech therapy referral. Yeah. So your primary care, your neurologist, whoever can, I'm sure they would be happy to refer you to speech therapy. Yep. Yep. Yes, ma'am.
Do you want to speak just for a minute to the difference between LSVT loud and the speak out? Because there was a speaker on that a while ago at one of our meetings, and Jim's actually done both.
Okay.
But I'd be curious to what you would say about the difference.
Yeah, I'm going to be honest. I don't know a lot about speak out because I did not do any training for that. I did the LSVT loud. So you may actually know more than I do about it. And I'd love to hear your input. But I think the goal with speak out is not as intensive as LSVT. And so from what I hear, it's kind of harder to carry that over and generalize it to daily life. But other than that, I'm not fully sure if you guys have experience on what you've noticed. I'd love to know.
It's like other therapies. It's a once a week with supposed to do homework in between. I'm sure that's the key to both of them.
Exactly.
And that's what we talk a lot about. Doing the exercise.
Yeah. And I will be honest, you may go through LSVT and then a couple months later, your family members are saying, wow, you're really quiet again. But the idea, even after you're done, every single day, you're supposed to keep doing those LSVT exercises, at least for 10 to 15 minutes. And then, if you need to kind of like check back in with a speech therapist here and there, like, once a year or something, then that's okay too. And that insurance would cover that as well, Medicare. Yeah. Yeah. Yes, sir.
I did this over the internet. Yeah.
Okay.
And it turned out that to schedule as much as we could squeeze in 4 a week for a long, I had to see all 3 therapists. Now this taught me a lot because each one had a very different approach to the same procedure.
Okay.
And they have to be, I'm suggesting from my perspective, from my personality, they have to be a bit aggressive and insist, right down to my last personal visit up there to see the otolaryngologist.
Yes.
The therapist jumped out of the room and greeted me, and I said something. She said, "What?" Because she just said, "You'll remember this when you really had problems." But can I just comment that maybe everybody will understand? I grew up not thinking about how my voice projected. I generally speak from right here. And that's one thing we're trying to get people beyond. If that singing training would bring something to that. But right now I can tell I'm doing okay, but I tend to fall back into talking right here, which will never have the resonance. I think you probably gonna give us this chart, shows, you know, if your regular voice, you're here, but to do it with Parkinson's, you gotta pick it up 2 notches or whatever. It's gonna sound loud to you, and it's not really sounding loud.
Yes. Yes. Great. Yes, sir.
The programs on the computer that you have for vocal projection as well as for dictation,
Mm-hmm.
so you can set the loudness in those things. And I'm wondering by using something like that on your computer where you would have your wife listen to that particular level and then turn it on the computer and you can barely hear it, you know.
Yeah.
Or
Yeah.
vice versa, you're too loud. So we just thought that might.
Yeah. Absolutely. That's great input for sure. All right.
It sounds a lot louder when you have hearing aids.
Yes. 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 For sure. All right. Well, I'm going to move on. I'll be happy to talk to anybody else, you know, one-on-one if you would like to talk about LSVT. I just know we're going to break out in a few minutes to do our breakout session. So let's play the video if we're able to, just a testimonial about LSVT. Yes. Yes. Thank you.
When we met, you hadn't had any treatment before.
None at all.
So tell me a little bit about before we started LSVT loud treatment, what you were noticing, what other people were noticing with your voice and speech.
I was working then with the fire department, and it was important for me to communicate. I was the chief of the department, had board of directors meetings and a lot of communications with the firefighters and command officers. And I began to notice as well with the physical limitations that were developing, my voice seemed to be softening. I didn't pay a lot of attention to it, but the firefighters would say, "Huh?
Okay.
Could you repeat that?
Okay.
Didn't catch that." And so we were spending a lot of time rehashing things that had already
Okay.
been said.
Do you remember when we first started doing LSVT, where you started to get that awareness that, oh, it's my voice that's too quiet?
In your office is where it happened at. The first sessions of awe. You kept telling me, no, let's get a strong, louder. And I'd go, geez, that's pretty loud. It felt loud to me, but you kept driving it further and further. You got to be louder and louder in the exercises. And then I started to notice that there was a difference, that sometimes I'd be loud and sometimes I wouldn't be so loud. And I was starting to pick up on the differences because I wasn't maintaining consistency with my loud voice, which your sessions really trained consistency into me. That this is a life experience change, that the exercises work, and it will build your confidence. It will help you to succeed where we have difficulties physically succeeding. This is something you can capture. This is not a difficult program, but it's a program that continually reminds us of what our voice can be. Please don't stop. We're going to whip this someday.
I just think he's the cutest man. All right, so that kind of
When I was a student, I'd write long essays that
about cognition and cognitive communication. So really quickly, I'm going to just cover that. So as speech language pathologists, yes, we also work on cognition. Now we also, neuropsychologists also would kind of be the ones to diagnose and have different areas within cognition that they find maybe are stronger or some that are a little bit harder. And then they may send you to us for treatment, but treatment typically looks like using compensatory memory strategies. So we'd give you some strategies of how to kind of help support memory. And then wherever else, when we do our assessment, whether it's attention, executive function, problem solving, those areas, if we pick up on that there's some areas lacking with that, then we would do just different activities in therapy that kind of simulate that and develop goals based on what you want to get back to and what's difficult for you. Then we would just do activities and treatment tasks to kind of simulate those things and practice them with cues so that hopefully with repetition, things would improve. That's kind of the gist of it. Did you have any specific questions about cognitive communication?
Well, the branch of the LSVT has planned in follow-ups sessions. And the difficulty a lot of times is you can't find the word. Not a matter of speaking the word, a matter of what is the word I'm supposed to be saying that I can't say.
Yeah.
Because just the ability of not being able to search and find it.
Yeah.
I think this is great for once you've already got the word that you want to say, but actually getting to the step before that is much harder.
Okay. Yeah, that's a good point you brought up too. So being word finding, being able to find the words you want to use, sometimes it'll be kind of on the tip of your tongue, or it might not be there at all, and you're just having to search in your brain for that word. That is another area that speech language pathologists can work on. It's more of the language centers of the brain. And there's just different strategies, word finding strategies that we have to offer and practice going through those strategies to kind of help you retrieve those words, or education to your family and caregivers on how they can help you with that too. That's kind of the gist of what therapy would look like for sure with that.
Same schedule.
No. It would just depend on what we felt you needed, whether it's one time a week, twice a week, follow up once every other week. It's not as intensive as the LSVT. No. Yeah. Unless we felt like we needed it. All right. Any other questions, comments, concerns for me? I'm happy to talk to anyone else on an individual basis if you'd like. I know we've got it scheduled to break out into groups. Any other questions? Okay. Is there someone here that's facilitating the different groups? Oh, good. Okay, awesome.
Thank you.
Thank you guys.